Thank you all for joining us today. This is the Center for Healthcare Policy and Research seminar series that we have weekly on Wednesdays. We have a mix of people in the audience, including students, some of which watch the recorded lecture later on as a part of a public health seminar. We also do some CME credit, so the code is in the chat if you're here for that, and then also our amazing core faculty affiliates, staff, and others who are just here for the content and to learn more. And as I always say, this is like our time to go between our missions of clinic-based research, community-based research, policy and practice-oriented research. And so our guest today actually does do a lot of those things all together in his research area. So we're really lucky to end this academic year with Dr. Jorge Rodriguez. I've had the pleasure of working with Dr. Rodriguez for a number of years now, but he is core faculty and assistant professor at the Brigham in Boston, Massachusetts. He is certified in both internal medicine and also informatics research, and he's a practicing hospitalist there. And really, how I know Jorge is through our shared love and passion for research that's at the intersection of justice, health policy and implementation to advance technology to improve health for all, so which I think is some of the content that he's going to share with us today. And he says he's welcome to take questions throughout his presentation, but will be opportunity to also have a small Q&A at the end. So we're very fortunate to have you here today, Dr. Rodriguez, and please do take it away.
Thank you so much, Courtney. Thank you for the invitation. And I will say the first time I interacted with Courtney was I was a youthful, I think, resident or something. And I just emailed Courtney randomly, and I was like, I read your paper and I'm so inspired. And Courtney was nice enough to be like, let's chat. So that's Courtney's always supportive all around. So thank you, Courtney. So I'll share my screen here in a second. There we go. There. Boom. All right. Share the screen. Can I get a thumbs up? Folks can see everything okay? Great. All right. Well, thank you again for having me today. Really excited to share with you all. I'm really going to focus a lot on continuous glucose monitoring. Is going to be sort of a big topic of the talk. And I will say you guys get a little bit of a different vibe because all of this stuff that I'm showing, I feel like I'm like some sort of like artist. You know, when you go to a concert and like you're like go to see an artist. Not that I'm a musician that you go see, but usually you're like, are they going to play their old hits, or are they going to play like their new stuff? I'm giving you the new stuff here, so you guys are getting the fresh look at this. And well, yeah, I think it'll hopefully creates good conversation here all around this. So to start, I have no disclosures to report. I want to get a sense if you guys can open up your chat and get your fingers typing ready. Just get a sense of the crowd in terms of your familiarity with continuous glucose monitors. So if you can just open up the chat and then just type in 1 for very familiar, 2 with somewhat, and 3 with not at all. And for any survey researchers in the crowd, allow me some grace. I know this is not the most methodologically rigorous survey, but allow me some grace there. All right, let's see what we got here. 1s and 2s. Okay, folks, 1, 2. Okay, mixed bag. Had a lot of 1s to start, but people ended up in like the 2 or 3 range. Okay, so somewhat. All right, so we got a mix. All right, great. I love it. All right, thank you for doing that. So we're going to cover a few different things. One, we'll start off with just kind of laying the groundwork, diabetes burden. We're all probably fairly familiar with it, but just kind of to make sure we're all on the same page. We're going to briefly look at the role and evidence for CGMs. And then I'm really going to focus on 2 main studies that we've worked on. One is around CGM disparities, and 2, it's around thinking about how our CGM metrics correlate or associate with our kind of gold standard of HbA1c. Then we'll talk about some future directions, and I'll kind of leave you with some overall take-home points. So to start, you all well know diabetes is a very prevalent, very morbid condition. Around 38.1 million adults have diabetes. It's a little bit over 1 out of every 10 adults have diabetes. And I will say that when I'm talking about diabetes, obviously acknowledge that there are different types of diabetes. Type 2 diabetes makes up around 90 to 95% of the folks with diabetes. So usually referring to type 2 diabetes for the most part in this work. And a lot of the works that I do in adults and older adults too. And so a lot of the focus ends up being on type 2 diabetes. And then the other thing I'll highlight here is that, pre-diabetes, sort of kind of the stage leading up to diabetes is also quite prevalent, even more so. 1 in 3 or 98 million have. And then there's a whole slew of folks that don't even know that they have prediabetes, but they do in fact have some level of glycemic dysregulation. And that'll become a bit more relevant in the second half of the talk when we talk about our second study. And so when we think about downstream of diabetes, you also think about their complications. Obviously, kind of key things here: leading cause of end-stage renal disease, leading to dialysis, leading cause of blindness, eighth leading cause of death, and lots of complications related to heart disease and stroke and amputations as well. So, but overall, kind of painting a picture, a very prevalent, very morbid condition that's important to focus on. But when we dive a little bit deeper in and we start looking at what the kind of the demographics of the patients who have diabetes looks like, we start noticing some disparities in the prevalence of diabetes by race and ethnicity. We see here that patients who are American Indian or Alaskan Native are somewhere in the 13% range. Black patients are around the 12%. Latino or Hispanic patients are just under 12%. Asian patients are around 9%. And then non-Hispanic white patients are in the 7% range. So you see sort of this gradation, and often see that folks in our marginalized communities tend to have more diabetes and thereby experience a lot of the complications downstream. And then really relevant to our conversation that we'll have here today around language preference. There's evidence to show, and this is from our good colleagues over at UCSF, showing that Latinos with non-English language preference have a 24% higher odds of having poor glycemic control. And I'll say that I'll stop here to reflect on the fact that language preference not only affects your glycemic control, but has broad impact on kind of quality of care, outcomes across the board, patient experience, patient understanding, patient adherence to medication. So sort of this broad swath of potential impacts that language preference has. So I want you to keep that in mind as we sort of talk through the rest of the talk here, at least the first study that I'll share with you. And so what are some challenges with diabetes care as we think about, kind of problem solving for some of these challenges? A lot of diabetes management is self-management, doing all sorts of different things, including measuring your blood glucose, very important. And one of the ways people do it, obviously, are finger stick monitoring, which I don't know if you all have tried it, but it's quite painful. And so if you can imagine doing this 3 to 4 times a day. I remember I was testing it out once and I got it made me clammy. My vessels clamped down. I poked myself, blood wouldn't come out, I poked myself again. So it's a very painful experience for patients. So it sort of makes you wonder whether there's some other way we could measure their blood glucose that's a little bit less painful. Two, from a clinician standpoint, it gives you you end up relying on a single data point, right? You have your HbA1c that gives you about 2 to 3 months of kind of glycemic control, but you're sort of making, if folks aren't measuring their blood glucose, you're making these pretty major decisions about medication just with this one data point. And as clinicians or non-clinicians, we like to make decisions based on multiple data points. We have a sense of what's going on. And then that leads ultimately to therapeutic inertia, the lack of data. You're I'm not quite sure. Maybe I'll just kind of stay, kind of keep the status quo rather than increasing or decreasing medications. And the other thing that we miss with our current status is a lot of hypoglycemia. So this is especially relevant for older adults that may suffer increased rate of hypoglycemia and leading to falls. And so it's another kind of important way we're kind of lacking data. It gives us less information on glycemic variability. And I'll share here that glycemic variability is increasingly being looked at as another potential measure that might be correlated with downstream either macrovascular or microvascular complications from diabetes. So A1C gives you just control, or you're just are you just in the range that we want you in? But if you think glycemic variability is about how the ups and downs of your day-to-day go. And so there's some interesting early data looking at that. So there's another area where we feel like we're missing something, we're not getting the full picture. And so enter continuous glucose monitors. And so continuous glucose monitors are devices, as you can see here, that are applied in multiple places, usually in the upper arm. And they provide interstitial glucose levels about every 5 minutes or so. People can wear them around every 14 to 15 days. And the application is not too bad here. I have an applicator here in my hand. You just kind of put it here, put the arm, and you have this little button that you click, and then boom, then you have a continuous glucose monitor that'll last you for about a couple of weeks. And so this is sort of a new way. It gives you a new way to look at someone's glucose control and variability. And so people have started looking at this. This is summarizing here sort of years and decades worth of studies, but essentially a lot of the evidence for CGM initially came from folks with type 1 diabetes. But increasingly in type 2, we've seen evidence of improvement in HbA1c compared to traditional glucose monitoring, decreased hypoglycemic events, decreased healthcare utilization as well. And this has been shown in both people who take multiple daily injections of insulin, just basal insulin, and those are probably the strongest evidence. And then for people without insulin, there's also decent data, but not as robust, but still kind of seems to say that there's a benefit to having folks wear this. And so as this data starts building up, you start thinking about how this technology is going to get out into the world or diffuse into the world, if you think about diffusion of technology. And so part of that always comes to coverage. I know someone in the chat mentioned about, questions about coverage with a lot of this. And so this is from actually a couple of years ago now, where Medicare expanded their coverage of CGM. It used to be that you needed multiple doses of insulin a day. But as you can see here, and some of the key things that they wanted are obviously having diabetes was part of it, being trained on the CGM, having it prescribed in accordance with the FDA indications, and then most importantly here is that it just required you to have insulin of any sort rather than multiple times a day. And so this was a key change in the coverage of CGM from a few years ago. And so again, it sort of starts expanding, like, okay, insurance covering a little bit more. Maybe I've told you about the benefits of it and some of the challenges that it helps solve. So it makes you think about how this technology is now going to diffuse in kind of like in the real world. So if you guys, again, open up the chat and get ready to share, this is going to be an open-ended one. So there are three technologies on the screen here: patient portals, telehealth, and mobile apps. What do these technologies have in common? And while you guys are thinking, I'm just going to tell you a little bit about each. I mean, patient portals, obviously the main patient-facing tool that exists in the healthcare system, really kind of took off with the HITECH Act. Telehealth can mean many things, but usually, kind of like synchronous video or audio visits, and really took off during the pandemic. Mobile apps have been around for a while. I feel like they've lost a little bit of their oomph and interest. I think at some point someone made like the comment like an app a day keeps the doctor away or something. I feel like we're no longer in that space, but let's see. Okay, great. People have been chatting. I love this. All right, let's see what we got here. Online health platforms need a smartphone tech literacy, requires device, higher accessibility of info for patients, patient-facing tech, accessible on multiple devices, digital health. Love it, love it, love it. Okay, yes, these are all true things. And also, yes, and also, they really reflect all points where diffusion of technology has revealed technology disparities. So this is data from our organization where we looked at telehealth specifically, and we showed that the proportion of people using video visits, if you think of video visits as a more complex technology, kind of varied by patient demographics. As you can see there, patients who were older, Black, Latinx, Spanish speaking, I'll highlight here for the sake of our conversation, and areas with low broadband all had lower use of this technology. So it naturally makes you wonder, I just told you about this emerging technology. What does diffusion of this technology look like? And so that's the point of the first question here. Who's getting CGM? And specifically, because of the work that I do, how does language preference affect CGM prescribing? It was a very kind of straightforward question that we wanted to look at an organization. So I'm going to tell you a little bit about it. And so we did this study at Mass General Brigham. We looked at adults with type 2 diabetes who received primary or endocrinology care for a couple of years, the beginning of 2022 to the end of 2023. And then we identified patients with diabetes using an EHR-based algorithm. I'll stop here a little bit to kind of dive into the identification of cohorts of patients in EHR data just very briefly, just because I find it kind of interesting because it affects the way your denominator to some extent. So I think it's important to mention. So there were sort of like three buckets to look at this. One bucket is sort of your classic, more code-based. So you use like an ICD code, and you use like E11 or E10, which are the ICD codes for type 1, type 2 diabetes. So that's one way to do it. Then there's another way, which are sort of rule-based algorithms, which really rely on you coming up with a set of rules. So for example, okay, I'm going to look at people who have an A1C above 6.5 and have had a visit with an ICD of 10 and are also on insulin or metformin. And you can imagine like a series of rules that you would go through to identify folks. There's some newer, fancier ones which use fancier math, which I do not know because I'm not a mathematician, but they're probabilistic models which essentially help you identify patients through using all of the EHR data rather than sort of more rule-based, a little bit more free form. So in this case, I just highlight that because it's an important piece of how you kind of assess and take a look at when someone's working with EHR data. In this case, we use the middle of the ones that I told you, the rule-based one. We use one of like the eMERGE algorithm, which has been validated over a few different sites. And the other nice thing about the eMERGE algorithm is they provide you with pseudocode. So if you want to adapt it into your own, usually SQL database, you can do that as well. That does take some level of adjustment and zhuzhing and to be able to do it, but you are able to do it. And I think the other thing I'll highlight here that I think is important for when you're doing this work is the importance of this chart review. I think when I started doing this work, I thought like, oh, just code the algorithm and it'll go, and then I'm done. Don't have to look at the chart. But it's really important to do chart review to make sure what you're extracting is actually what you're finding in your data set. So I sort of wanted to stop there to really highlight that point. So back to our study, we've now identified people with type 2 diabetes, and we wanted to look at our primary outcome, which was really CGM prescriptions and more specifically CGM orders. So we went in the EHR, and so anytime a clinical staff member, clinician was like, I think this person could benefit from a CGM, let me put in an order. And then once they put in the order, we would capture that as a yes, at least someone put in the order. Granted, downstream from that, there's a lot of considerations around insurance and other pieces of the puzzle. But we just wanted to take a look at like, are the people's prescribing patterns different? And we included a few different patient demographics, insurance, clinical factors, and care type. By care type, I mostly mean, were you only seen by primary care? Were you only seen by endocrinology? Or were you co-managed? Were you seen by both for that? And so we ran multivariable logistic regression, and then we also calculated predicted probabilities from those models. Getting to a little bit of the results here, we ended up with around a little bit under 70,000 patients. 12% of them had non-English language preference. And you got the sense that the folks who are in this non-English language preference population tend to be older, more Latino, not surprisingly, as Spanish is most common language in our population, more public insurance, but you got the sense that they were sicker. There was like more use of insulin, more uncontrolled diabetes. And then the other point I don't note here, but that was kind of interesting, but we just found out as we were going to, they're less likely to be co-managed with endocrinology. So they're usually managed only with primary care, but essentially sort of a kind of a sicker population when you look at the use of insulin and uncontrolled diabetes. But despite the sickness, your kind of like a priori hypothesis might be, well, that these are the folks that are getting the CGM because they are sicker, and you just told me how great CGM is. But in fact, no. When we looked at the results here in the yellow, you'll see that folks with non-English language preference had about 8.5% adjusted predicted probability, and folks with English language preference about 12.6%. So about like a 4% difference in sort of just the ordering patterns of this. And so in order to confirm this, we did perform some sensitivity analyses, finding that, for example, amongst people with uncontrolled diabetes, so even sicker population, these sort of same patterns persisted. People only on insulin, again, sicker populations, these patterns persisted. So it seemed to be pretty consistent with a difference. We can sort of surmise a lot of reasons why that might be, but there was at least at kind of face value, a difference in the way people were prescribing CGMs. The other thing I'll note here that we did here was I've been getting really interested in looking at the subgroup analyses around folks with non-English language. Non-English language, obviously, very broad. There's so many languages in the world. What does that non-English language mean? And so, I think someone's experience as a Spanish speaker is probably vastly different than someone's experience as like a Haitian Creole speaker, just because of the nature of the resources, the kind of more people speak Spanish. And so we wanted to take a look at that for this. So we did a subgroup analysis looking at patients, only on patients with non-English language preference, comparing Spanish preference to non-Spanish speaking preference. And to my surprise, we found no difference. There was no difference between those two groups, so suggesting to me that perhaps just not having English preference is enough. And maybe once you maybe whatever language you speak other than English seems to influence things less, at least in our population. So that's sort of an unexpected finding that I thought we would certainly have a difference between Spanish and non-Spanish, but we did not. And so where does this paper sort of sit in the context of the larger CGM literature? And so this is a paper from Walia and colleagues that came out late last year in JAMA Open that looked at the technology CGM disparities by a few different things, including race and ethnicity. They did not look at language, and they found that again, patients who were Latino, Black, or uninsured were less likely to get CGM. And so our study sort of adds to this growing literature to show that language also plays a role in the way CGM is diffusing. And so this paper is currently in press, and it comes out in a week and a half. So watch out for it if you're looking for a paper to read in a week and a half. You can dive in, or our paper. This paper is already out. I mean, I meant our paper. And Courtney's in that one actually. So Courtney will be making showing as well. But that brings up a larger point around how technology diffuses, as I mentioned, through the technology, and this larger point around digital health equity. So if you all wouldn't mind participating again, getting your hands up, type in the chat, how do you define digital health equity? Let's say you're like a healthcare leader, you're trying to lead an organization, and they're like, how do you, Mr. C-suite, Mrs. C-suite, how do you define digital health equity at this organization? Just type it in the chat, and then I'll share with you what other folks said throughout the country, so you get to see how your definition stacks up. I'll give you a few minutes to do it here. And I'll get the brains are going. They're going. And this is, as I said, this is a question that we asked a group of folks throughout the country. So I'll be interested to see what you all think. Let's see what we got here. Oh, they're coming through. Great. I see. I'm just going to read these out. Patient empowerment. Okay. Monitor glucose spikes, fair access digital tools, reducing barriers to access. I'll give it ensuring equal opportunity of benefits for the patient population. Love it. Thank you. Or I'll give it 10 more seconds. Oh, and they're coming through. Oh, okay. All people have access to skills to use digital tools to improve their health, enabling intended outcomes of health tech, reaching maximum impact all expected patients. Loving it. Great. All right. These are awesome. Ensure access and ensure technology are beneficial to everyone regardless of their background. I love this. So this is now we got a sense of what you all think. This is the next part I'll share with you here is a little bit about a project that we did with looking at a bunch of healthcare leaders throughout the country. So we went and spoke to about 12 different sites, and we spoke to their digital healthcare leaders and their health equity leaders, and we asked them this same exact question. This is what they said, the summary of what they said. So some of them said using cost-effective digital tools to support access to care and health equity. Others said providing all patients with access to care that is supported by but not limited to digital tools. So okay, so some understanding that digital tools is not everything. The first person was wondering about cost in all of this. That's sort of an interesting thing to think about. Healthcare system using digital tools to advance health equity. So sort of digital tools as a tool to get you to health equity. That's good. And then involving all populations in the development of digital tools. So this understanding that it's not just about applying the tool, it's about sort of upstream. How do you design and develop all of these things? And so I sort of stop here to share with you how I define digital health equity. This is not there's no one universal definition, but this is adapted from the definition of health equity. And so this is just everyone should have a fair and just opportunity to engage with and benefit from digital health tools, including things like CGM. And so when we think about this, I'll briefly mention sort of these large domains that I think about all of this in. One, in terms of digital health equity, one is the overarching here around leadership and strategy. So this exercise that we all just went through to define digital health equity, it's important, I think, as an organization to go through that and try to understand that, because I think that'll guide your next steps. Obviously, there's a few folks that in their definitions mentioned both concepts of technology access and technology literacy in order to use these CGM tools. Not for all of the types of CGMs, but for some of them, you need to be able to have a device, you need to be able to have internet, you need to be able to know how to use all of these things. Obviously, that comes into play. Implementation, there's a whole other conversation to have, like how do you implement this at the clinic level, at the health system level? What are the pieces that were missing, why we saw those differences? policy plays a role. Obviously, insurance policy, like we just saw, Medicare expand its coverage plays a role. And the other thing that comes with all of this is standard of care. There's some interesting data in the patient portal literature showing bias in who gets offered a patient portal. And so I wonder about whether there's something similar at play here for CGM. Is there bias in the way who we're offering these tools to? For whatever reason, we just don't think they're going to use it or not use it. And so, or should we just offer it to everyone? One solution that I'll share with you that we've used in the patient portal space that I think could be applied to the CGM space is the concept of digital health navigators. This idea of having this new team member that helps integrate technology into their care. And so when we thought about this, and Courtney actually did a lot of the foundational work on this, the thought was around like patient portals was the big focus because that was the technology we're focusing on. But I think that's a really great starting point to then push us into, can we use this for other? Now there's remote blood pressure monitors. There's like CGMs that we're using, and these are all coming up in different contexts. And I think it's an important piece of the way we think about this. And so I'll share with you a little bit about our experience with digital health navigators, mostly in the context of patient portal enrollment. And so here was a pilot that we did over at one of our primary care clinics where we had someone, JP was his name, JP was great. And he basically outreach to patients who weren't enrolled in the patient portal and tried to enroll them. He enrolled about a third of them or so. And then overall, I think just the idea of bringing this attention more into the clinic's kind of thought process increased our enrollment of patients, especially those who were Black and Hispanic or Latino. And so that was one idea of it. And then the other piece that came into play was at a larger organization, Mass General Brigham, which, by the way, Mass General Brigham is a large academic health center in Massachusetts, in Boston. And so they had a kind of this digital health equity approach. It did many things, including translation and internet-enabled iPads. One of the things they did was a digital navigator program called Digital Access Coordinator Program. Really great program. It's around 10 to 12 people or so. They speak all sorts of different languages. And their main role is to really kind of identify folks who, have not used digital tool, perform outreach, enroll them, and educate on them. And so this is sort of pre and post data from an operational project where we were looking at how our clinics were doing in terms of their patient portal enrollment before and after the program. And as you can see here, for all the clinics, the numbers went up, which is good, which is what you want to see in this case. And so it really sort of highlights an opportunity here to leverage some of the same resources that we have to now apply them to, for example, CGMs. As I just showed you, there are differences in who's getting CGM, and this might extend to not just showing a patient how to use it, but maybe helping navigate some of the insurance or payment challenges that come up that other folks in the healthcare team don't have the ability to navigate. And so, with that, I'll sort of leave you with these takeaways from this project, which were really, obviously patients with non-English language preference receive CGMs less. And then as we continue to see an interesting pattern, remember, every time a new technology emerges, there's this delayed diffusion to marginalized communities. I always kind of ask myself, is the goal here really to get rid of the technology diffusion, right? The kind of like that curve that we see, or is it just to narrow it? And so I think it's an interesting question, because I think we'll continue to face it as like as LLMs and fancy chatbots take off. What is that gonna look like? So I think it's an interesting conversation to continue to ask and to continue to look at as new technologies come up. So that's all about CGMs. But the other portion of this, oh yeah, please.
Can I interrupt you? Sorry. Can
Sure.
you talk about, is that program still ongoing? The
Yes.
health equity program and how it's funded and things like that. That would be.
These are the hard questions you ask for. Yeah. So this is the program is funded through the organization. I will say that in terms of funding and support for it, I think a lot of it, this was a part of a larger effort called the United Against Racism effort that came throughout the organization. There was lots of sort of support, both kind of, just championing support, but also funding support. And then one of the pillars was digital health equity. It came up during the time of obviously a lot of social justice movements, George Floyd and things of that nature, but also when telehealth and patient porn, everyone was kind of thinking about that. And so I think they made digital health equity a portion of that. And so that's where the programs come up. And I think everyone really likes the program. I think that they've at this point enrolled over like 20,000 patients or so. And I think we're trying to expand it. I think the question that naturally comes up with all these programs is what's the sort of like the ROI, as they say, on all of these things. And so I think that's where we are doing some work to take a look at that. But it's all, I guess, to your main question was how is it funded? It's all sort of internal funding from the hospital that gets funded. But I will say, to the challenges of funding, the pilot program that we did was grant funded, and that one like was about to end, and then the organizational program came into play, and so that's how we were able to kind of continue a momentum. But had the organization not stepped in and say like, oh, we also want to do this, then we would have ended up in like the grant ended, the program's done. So I think funding is definitely a challenge. There's some folks looking at like more community health worker type models that for funding and stuff. So I think there's another option there. But I think funding is definitely a big question mark that makes this a little bit challenging to kind of probably diffuse and scale to like other places that might not be Mass General Brigham. So it's a good question. Any other questions before I transition to the latter half here?
I think that was the question in the chat, was the funding. So I think you
Oh, okay.
answered. So you're
Got it.
right on brand
All
for
right.
the types of questions we have. I think we'd all love to do this, but funding is challenging. Yeah.
Funding is yeah, no, I think it's a tough thing. I mean, some other folks have done it, and as well, Courtney, like through volunteering and other kind of like avenues to be able to just have folks who are engaged. And we do like over the summer, we have a couple of interns that join us and join the program, and they do some of this. So I think there are other ways to do it, but I do acknowledge that for a program like that, it's not it's the funding is tricky, though I think we all agree that there are important programs. The funding is a tricky piece that I do not have solutions for. I do not have solutions for. Cool. All right. So the next part of the talk was around what do CGM measures? What do CGMs measure? And so it really comes down to now someone might have a CGM, but it's not who you would expect to think, because last year the FDA cleared the first over-the-counter continuous glucose monitor. So now everyone can have a continuous glucose monitor. You have diabetes, don't have diabetes, everyone can have it. And so that brings up an interesting question, right? It brings up an interesting question about, at least for me as a clinician, what do I do when my patients start coming in and saying like, hey, I wore a CGM for a month and here are my numbers. I don't have diabetes, but should I get concerned about their metrics or not? And so we're going to dive in a little bit of a deep data dive here on all about CGM metrics. So this is a little bit of a case to start us off with. Here's a 39-year-old male, history of asthma, no diabetes. He's here for a physical. During the visit, he's like, hey, doc, I've been, I saw this, like they approved CGMs. I just bought one and started wearing one, but some of the values look kind of off. Like, kind of concerned. Do I have diabetes or pre-diabetes? I've been kind of stressed out about it. What do I do? And so this is the question you have before yourself as a clinician. And so what can you do? You were like, okay, let me take a look at the data, right? I want to take a look at what you actually saw. And so one thing you could look at would be the raw glucose levels. This is raw CGM data for someone that wore it for about 10 or 14 days. And as you can imagine, this is probably hard to, I feel like I'm trying to squint my eyes to see if I can make out what the exact pattern is. It's probably pretty difficult to do. All I mostly see is lots of ups and downs, but it's hard for me to say what exactly is going on here. And so that's where the role of CGM metrics comes into play. And so CGM metrics kind of summarize your longitudinal glucose data into kind of broad measures of either control or variability. And on the right-hand side here, you see one of my glucose data. So a few months ago, in October, actually, I wore a CGM for about a month. This is 2 weeks worth of data, though. And I was interested to see. I was like interested to see what it was like wearing it, what I would learn from it. And you can see here that it contains a lot of interesting values. It contains your average glucose. It contains something called your GMI, your glucose management index, which is supposed to be kind of an estimate of your A1C, as measures of glycemic variability, standard deviation, coefficient of variation, as this concept of time in range, which we'll get to in a second, but lots of sort of interesting things. But again, I'm a clinician. This person just came in. I see all these values, but in the back of my head, all I'm thinking is, what is the A1C, right? A1C is our gold standard that we use. If someone asks me, what's this person's glycemic control? I'm like, oh, what's their A1C? So that's the back of my mind. So how do we connect the two? And to give you a little bit more on time and range, just because it might not be a familiar concept, time and range basically reflect how much time or percent of time that you spend within a certain range of glucose. And so in this case, it's 70 to 180. Sometimes for another measure you have is time in tight range, where you look at 70 to 140. And so for diabetes, usually the goal is about 70% or above. But in our case, our patient doesn't have diabetes. So what's the goal for this patient? Should I be worried if I start seeing fluctuations, some highs? I'll tell you all a brief story. When I had a high level, there was one day where I was going to have lunch, and as I said, I don't have diabetes. I was going to have lunch, and I got a soup. I was like, soup sounds healthy, right? I had some rice noodles. I was like, that can't be so bad. I had the soup with the rice noodles. My glucose jumped way up. And so what does that reflect? And so this is the kind of question that I think kind of brought on this next study that I'll tell you about. And so the goal of the study here was to determine how key CGM metrics correlate with A1C across the glycemic spectrum, with the idea being that as a clinician, if someone shares with me their time in range or their mean glucose or their GMI, how can I trust those values to reflect back to my usual gold standard, which is the hemoglobin A1C? And so in order to do this, we use this really great data set, and I will stop here. I don't usually stop and do like let's look at the data set, but I think it's such a great data set. I think everyone should know about it, and you guys should use it for your own studies. This is the AI Ready data set from the Aim Ahead program from the NIH. It's a really rich and amazing data set. It's their goal is to get to 4,000 patients. Right now, they're about 1,000. This is the second version of their data, and it contains such a rich amount of data. It has people were surveyed, they received surveys, patients had EKGs done, they wore CGMs, they wore like a Garmin watch, which gave you heart rate and sleep metrics. They had environmental sensors placed in their house to capture both light and environmental pollution. And they also had retinal screenings looking for diabetic retinopathy. So that's why it ends up being about 2 terabytes of data, because all that imaging data. I had to get actually an external hard drive that I have right here to be able to capture all this data, because it was just too much. But I think I highlighted here because I think it's a really great data set. It has also lab values like A1C and other things that you can. The point of it was to build AI or ML tools, but you can do other sorts of studies on it too. It has interesting things with like surveys around social determinants of health, if you're interested in that. And the way to access it, I think the biggest limitation to access it is just having a place to store all of it. But other than that, it's pretty easy to get access. You fill out a simple application. So I sort of highlight that just as a cool data set that is just came out recently, grossly underused, and and I should say all focused on people with and without diabetes. It's a diabetes focused data set. So that's my quick plug of this data set. So the data set includes the patient population here that we worked on, people older than 40, with and without type 2 diabetes. There are a few different exclusion criteria there. And the other interesting piece around this is it was across 3 sites. So you got a little bit of a sense of the country. You have the University of Alabama, you have your colleagues at UC San Diego, you have University of Washington, all represented in this data set. And so, as I said, we wanted to specifically look at CGM metrics for this. And so we chose 9. Some of them were clinically interesting. Some of them were kind of research-wise interesting. And so as you can see here, for glycemic control, we looked at mean glucose, GMI, time in range, time in tight range. For glycemic variability, you get into the series of various types, which are less clinically relevant, but more kind of like research relevant. But they're all some level of a measure of looking at the raw data and doing some math calculations on it and coming up with a measure of variability. And so you have like the MAGE and MOD, and my favorite one, which is Conga, because who doesn't like the one called Conga? And a standard deviation. The J index, though I put in the glycemic variability, it's actually a combination, measures both control and variability. But again, I'm sort of may receive all of this as a clinician. How does it go back to my gold standard of A1C? And so in order to do this, we did stratified linear regression with robust errors. We adjusted for body mass index and age, which can influence your hemoglobin A1C. And then all of these analyses were performed R. And then I don't usually go into like the details of what the analysis was, but I do here, because I will give a shout out to the iGlue package, which is an amazing R package for those that want to work on this data some more, which usually calculating all of these metrics I just told you, writing them out would take a long time to be able to do that, like to figure out all the math calculations and everything, all the equations. But the iGlue package, I think it's University of Michigan, I want to say, that developed that's one out of there. There's a reference there, but it really allows you to like very quickly get, you can get like the top 10 metrics in the matter of like less than a minute for like a series. I think they did it across I think it's 972 patients that we had. And so really useful package if you're interested in that and like data-y things. But let's get to the results here. So this is the population we looked at. We had, again, 3 groups: type 2 diabetes, prediabetes, and normal glycemia. As you can see here, the folks who had normal glycemia were a little bit younger, lower body mass index. And then, as expected, there the hemoglobin A1Cs were different, as you would expect, because that was part of the criteria for the groups that we had. The one thing I'll highlight here is that people with type 2 diabetes, their A1C was 6.7 or so, with a standard deviation of 1.3. So it was sort of like a kind of healthier, I would say, group of folks that maybe a little more controlled. And so that maybe speaks to a little bit of, maybe a selection bias or something in terms of who's participating in this study, just because they do tend to be a little bit on the healthier side relative to what I think we would see if we just looked at the whole population. But this is our population. And so what did we find? How did some of these metrics connect back or associate with hemoglobin A1C? And so I'll show you the first one here, which is mean glucose. As you can see in the orange there with diabetes, you have a pretty nice slope, right? The estimate that we see there is like around 0.8. So the pretty good association between hemoglobin A1C and your mean glucose. But then you start noticing something interesting as you go down into prediabetes and no diabetes. The slope tends flattened out, 0.22, 0.1. And so that suggests to me that this correlation between mean glucose and your predicted A1C ends up kind of attenuating as you go down and you get kind of better glycemic control. And so the other things that we did in this study to take a look at this and confirm this a bit more, one, we also ran some models controlling for hemoglobin. So we had hemoglobin in the data set, and so anemia can influence your HbA1c. We controlled for that as well, and that also maintained the same patterns that you saw here. We also ran one thing that we have to take into account here is that when we're running linear regression, we're assuming sort of less variability and usually the outcome compared to the predictor variables. But in this case, we know that hemoglobin A1C as the outcome does have some measurement error, some variability, as do the metrics. And so both sides of the equation have measurement error. And so linear regression doesn't account for that. And so we had to run Deming regression. And so Deming regression allows you to include a variable that gives you kind of like an error factor of how much kind of error measures your error. And so when we did that, we also found kind of the same pattern again, sort of this attenuation of correlation between hemoglobin A1C and mean glucose. And you might be asking yourself, cool, but what about the other metrics? Sure, here are the other metrics. And so when we looked at all the metrics, the patterns were surprisingly similar. There was the same thing. They were like, and they were pretty good for diabetes, okay for prediabetes. By the time you got down to no diabetes, they were pretty flat. And so it's interesting to think about how I might sort of interpret this as I'm seeing someone without diabetes. And so, I'm not the only one to wonder about this. This was a really interesting study for one of our collaborators actually on this is Dr. Spartana, who's our collaborator on this prior paper and also did this paper, where they gave basically a series, I think it was like, I forget if it was 18, maybe more, 18 or 20 clinicians, very experienced in CGM, and they gave them sort of like the CGM metrics for a series of folks without diabetes. And they're like, what would you do with this? And there was like not agreement on what you would do. Some said gate an A1C, some said, just follow it up. I don't, really need to look at it. And so it's an interesting piece around how you might think about this. And so when I see this, I have with this case, the next step I would do, and clearly no one agrees into what the right answer is per se. So the next thing I would do would be a hemoglobin A1C, mostly because like that's my tried and true. I know I can trust it. But it does bring in some interesting points around some of the key takeaways here. Looking at the use of CGM, I think will continue to expand in people without diabetes. It's now available over the counter. There are at least 2 major companies that provide it. Interpreting these CGM metrics in people without diabetes, I think, should be done with caution. And I think there's a general need for new threshold or new metrics in people without diabetes to help us understand what's normal, what's not, how does it relate back to hemoglobin A1C. And so I think it's an interesting time for understanding this because there's not a ton of papers, can maybe like a handful, if that have looked at CGM in patients without diabetes. And some of the findings that we had here are maybe not surprising, right? It's like, well, a lot of these metrics that were developed were in people with diabetes. So you're now applying this metric to a different population. So you're going to find differences, but those are the metrics that we have. And so those are the ones that we're going to rely on. So we might need to adjust things a bit here, but still work to be done. And so with that, I'll sort of leave you with a few parting thoughts here in the last couple of slides. One, I think that overall, obviously, in order to ensure that technology diffuses equitably, we got to really think about the way we implement it. Two, I think there's an interesting piece around CGMs and behavior change. So one thing I didn't tell you early on is a lot of the studies that support CGM use in people with diabetes, when you actually look at why their A1C got better, you find really no big differences in medication change. That's what I thought, like, oh, people are seeing the CGM and then they're like getting the new data and they're like, let's increase your insulin, let's add another medication. But in fact, some of the data shows that there's no difference in medication change between groups. And so it makes you wonder what other things might be driving this improvement in A1C that you saw in the CGM group. And so I think there's might be a component of behavior change in this. And so can we use this as sort of like a biofeedback tool to not only amongst people with diabetes, but also people without diabetes to sort of promote change? And I think it's different than when you think about like, doing your like scale every day, right? Because if you do your scale, it's every day. You're like, oh, my weight went up, it went down. What was it about yesterday? Here, you're now getting like real time. Like when I ate the bowl of soup with rice noodles, I was like, oh my gosh, it was probably the rice noodles that made my sugar go up. I should maybe reconsider having rice noodles or have less of it. So I think it's more direct. I think it's interesting. The other piece here is I think there's some level of increased education that's needed around CGM metrics and how do we interpret those, especially as more people start having access to CGM. And I think there's all sorts of interesting questions around using these metrics and as sort of new ways to identify diabetes risk. And some of the work we're doing now, we're starting to look at, and you can sort of see it when you look at the raw data. You can sort of see these folks that like by A1C look like fine, but their CGM metrics look like a little bit more towards like the diabetes group. And so it makes you wonder whether there's something else, some nuance there that we might be able to capture with CGM to give us a sense of folks' diabetes risk in the long run. So that's sort of another point. And so with all of that, I'll say that I'll end on a little bit of a reflective note, right? We're at this point, we're all friends. We're all friends here. I can be open with you all. And so this is something I struggle with every day. And Courtney wrote this paper with me, so she knows it well. This struggle, right? A lot of this talk was very like techno-optimistic, right? It was like I was like, CGMs, there's new technology. We got to get it out there. Oh my gosh, we got to do all these things with it. But it assumes a lot of like positive, like technology is good. It's going to help us solve issues. But there's, I think, always a good balance of techno skepticism to say, like, where are we investing our time, funding, our effort? And sometimes when we invest in technology infrastructure, we might take away from investing in social infrastructure. So I think it's like that fine balance. And so Courtney and I wrote this paper where we sort of think about how do we balance those two pieces using implementation science to making sure that someone mentioned in their definition having maximum impact. So if that idea of like having that maximum impact in the way we're sort of investing and using all of these tools. And so I wake up every morning, I'm just like, where do I lie on this scale? Where do I lie on this scale? And then I have my oatmeal. That's my mornings for you guys. And then the last thing I'll tell you about is this is a collaboration with colleagues at UCLA, Dr. Alejandro Casillas, and over at UCSF, Dr. Lane Kuhn. We're trying to get community build around digital health equity, and so this is the Digital Health Equity Collaborative. We have a group, we have a listserv, and we also have semi-quarterly gatherings where we invite folks to share about their digital health equity experiences. And so we had our first session was all about digital health equity strategy, and we had like leaders kind of talk about how they approach it. Our second session was all around digital navigation, and that was great. And then I'll give you a little bit of a preview. This is secret stuff here, so don't tell anyone. The upcoming talks are around. One is around just around sort of how do we do digital health equity work in our current sociopolitical environment. And then the other one coming up is more about making the business case for digital health equity tools, and probably gets a little bit at that funding question that we sort of talked about earlier. So if you're interested feel free to join the listserv, or you can also email me and you'll get you on there. So with that, I want to thank you, Courtney and William. Thank you so much for the invitation, and everyone for taking a listen. And I'm happy to stop sharing my screen and take some questions if there are any.
Thank you so much. Such a great talk. I do see one question in the chat. Please do add other questions in the chat or come off mute. Glorieta, I will read your question, but you can follow up if there's anything that you wanted to add. She was wondering, when using CGMs, is there feedback about how to interpret the results or how to think about day-to-day fluctuations versus average change over a month?
Yeah, it's a great question. I think a lot of it has to do with like any measurement, just like why you're using the tool. I think that, if you're looking at something like, let's say you have a patient that you're increasing their insulin, you're like, oh, I'm a little bit afraid that they might have like low blood sugar and have hypoglycemia. Then the more day to day, you might look at like there's other measures called time that there's so many metrics. There's one called time below range, which has like 2 levels. And so time below range, you would look at that specifically, like how much time are they spending in the low glucose level, and that you might make adjustments. If you're just trying to get a sense, like a more broader sense of, you added a new medication, let's say you're not expecting a lot of hypoglycemia, but maybe you added a new oral medication and you wanted to take a look at how their glycemic control did over a month, then you might look at it over a month. And usually the CGMs last about a couple of weeks. So probably a couple of weeks is a good time to get a sense of like, okay, over the past couple of weeks, here's how things were looking for this folks. There's a whole other interesting question that I didn't get to here, but around the role of some of our GLP-1 agonists and how they sort of interplay with all of this. I haven't seen really any studies looking at like what how your CGM metrics look like when you're on a GLP-1 versus when you're not. That's sort of another open question. But I'd say to your question, Glorieta, is all around just like why they're wearing it is, I think, what influenced my interpretation, like how I would interpret them.
Yeah, and there's some other comments in the chat, I think with some personal experience, sort of backing up what you said, Jorge, when you wore it, which was, just that immediate feedback on how you've been using it. Because what I'm hearing you say is even though your metric study didn't show really that good of data for people without diabetes and using it, like in terms of you still feel hopeful that there are new metrics for potentially everybody or other people to use it as like a diet input or other input about how they're doing to improve health. Is that a fair? I'm just trying to say if that's a fair summary of sort of where you feel like the field might head.
Yeah, exactly. That is exactly right. I think the metrics are more just around like, what do I do with this data? Someone comes in, they're like, my time in range is low. Like, should I be scared? So I think it's more around that piece. But I think there's value in outside the metrics, just looking at how your day to day. For example, I learned like, wow, exercise really does bring your glucose down. After I ate those rice noodles, I went for a run and my glucose just like dropped down. And I was like, it was just like this moment of like, you sort of understand it conceptually, but to be able to see it and see it in your body, I think was like quite unique. And so I think, obviously, like that's not like with all these things, these are all like multifactorial. That's not going to be like the magic thing that you do. But, in terms of like leveraging other thing, diabetes prevention, all that kind of stuff that already exists, I think it sort of presents an interesting touch point of like, I think that's where the power is, like you're saying, that biofeedback to be like, okay, I ate this. Wow. Like, for example, I ate gelato. The gelato did not to be, I think it's because of the mix of like fat and protein. The gelato was fine, but I had the soup with the rice noodles and I was like, I would have expected the opposite. All these little things that you learn, I think are very useful.
I love this. Okay, I have 2 other questions in the chat and we have 5 minutes. There's a clinical question about, can you talk about interstitial versus serum glucose comparisons? Is there anything you want to share with us about that?
It's a good question. I don't know if we've looked at that quite as closely. We could look at with this data because they do have mean glucose. They have a serum glucose. So I will take a look at it and see if we find anything, but I can't
Yeah,
share with you right now.
I would imagine to get these over the counter though, they did some comparisons, right?
Oh, right. Yeah, that's true. Yeah.
Validate them against. I mean, I
validate.
imagine there's data on that. I'm sure they're not exactly the same, but trying to interpret based on what our gold standard on, which I
Yeah.
would imagine is also still blood glucose. And then, so I'm speaking out of my clinical range, but I just wanted to chime
You're
in there.
spot on.
And then I guess the last one we can end with here is a really great question from Alan in the chat, which is just that for their patients in the free clinic. It's really trying to teach patients about how to use the
Mhm.
device and how to interpret the curves that they see. And do you have any script or any educational materials or any other advice about how teaching patients for varying levels of health or digital literacy about how to use these tools effectively?
Yeah. There's a great group within our organization that doing a QI project on this, and I think they've developed scripts and things of that nature. We have some of our digital navigators have scripts as well in terms of like providing some of this information. It's something that we're trying to grow into, I'd say. So it's an active development. I'd say the one thing I'll mention here in terms of like the apps and stuff that are available, they are available, I think mostly in English and Spanish, which I think is obviously not all languages, but Courtney will tell you like we had probably done this 10 years ago, everything would have been in English and nothing would have been in Spanish. So there is a step in the right direction in terms of addressing some of the literacy and language concerns. But yeah, if you, Alan, if you want to email me, I can connect you with folks who've developed standardized scripts.
Amazing. A lot to think about from the broader implementation space, from specific examples of getting patients to use a new technology, and then also to, yeah, how to interpret it for everybody, like how to think
Mhm.
about digital tools to support behavior change for all patients. So just like a whirlwind of topics, Jorge, really
Mhm.
appreciate it. Do you have
Yeah.
any final closing remarks for us or any summaries for us? But this has been really educational, and helpful.
No, I want to thank everyone for the opportunity to share this. This was my first time given this talk with all this new data, so it was good to be able to share it. And I think, yeah, I would just say that always, I think I'm always my parting thought is to question the technology and don't get kind of swooped up in the hype and really kind of take that question. I think you all are doing that. Like, is this really helping our patients? Is this really helping us to get to health equity, or is it just sort of like another thing that we're gonna invest in when in reality investing in some sort of social infrastructure would have done have a bigger impact than investing in whatever the latest and greatest tech is. So
So relevant for all of us, especially in this AI craze. So I
yeah,
appreciate that. I appreciate your time. Thank you everyone for coming today. And you can reach out to Jorge with questions. He's very open to it. Thank you all. I hope you have a
thank
great
you.
afternoon.
Bye.
Thank you.